Good evening, and thank you for joining us for this special webinar on persistent erythema and rosacea. I'm Andrew Huff, Executive Director of the National Rosacea Society, and it is my pleasure to introduce Dr. Julie Harper, President and owner of the Dermatology and Skincare Center of Birmingham, and a member of the National Rosacea Society's Medical Advisory Board. Dr. Harper is a founding director of the American Acne and Rosacea Society and is the professional organization's past president. She is a fellow of the American Academy of Dermatology and served on the AAD's acne work group, tasked with writing acne treatment guidelines. Dr. Harper is also a member of the Women's Dermatological Society and a former president of the Alabama Dermatological Society. She was a clinical associate professor of dermatology at the University of Alabama, Birmingham through 2020. She has studied, written, and spoken on the subject of rosacea extensively, and tonight she will provide an update on rosacea diagnosis and discuss potential causes, the psychosocial impact of rosacea redness on patients, and treatment options for erythema. Please welcome Dr. Julie Harper.
Thank you, Andrew, for that nice introduction. And I would like to say thank you most sincerely to the National Rosacea Society for all that you do to help our patients with rosacea and really also to help us and to increase our knowledge. And so tonight, what we're going to be increasing our knowledge about is the erythema of rosacea. So this is my conflict of interest statement. So let's start by just looking at some patients with rosacea. And we're looking at kind of old photos and an old way of thinking about rosacea. So we're looking at people with the different subtypes of rosacea. So we see, old-fashioned erythematotelangiectatic rosacea, papulopustular rosacea, ocular rosacea, and phymatous rosacea. And now forget everything that I just said because we're not really thinking about phenotypes anymore, we're not thinking about subtypes anymore. And that's because if we do that, too often we're trying to pigeonhole people into a space where they don't fit comfortably. What I mean by that is, as you look at all four of these photos, which of these pictures don't have erythema? And the obvious answer is they all have erythema. And so that's such an important part of rosacea across the board. And if you spend too much time trying to put somebody into a subtype, for example, papulopustular rosacea, you may in the end be undertreating the erythema, which we know is an important part of rosacea as well. So we've moved from those old subtypes now to this phenotype approach. And this was published in 2018. And what we see here is we can make a diagnosis of rosacea now by just looking at the patient. Also, I would say by talking to the patient. But there's two features that when you see them on a patient, you can just be sure that they have rosacea. And one of those is fixed centrofacial erythema. The other is phyma. So if you see either of those, you've got enough right there to make your diagnosis. Now, without those, you can still make a diagnosis of rosacea, but those are the diagnostic features or the diagnostic phenotypes. But there's also major phenotypes or major features, and that would be flushing, papules and pustules, telangiectasia, different ocular manifestations. We also see secondary features. And I would like to remind us that rosacea is not just what we see, it is what our patients feel. So rosacea, we know, also has symptoms, and that's much of what we see listed there, things like burning sensation and stinging. So it's not just about what people see or what we see, but it's also about what they feel. But we're going to today be talking about background erythema, and it doesn't mean it stands alone. Please do not misunderstand and think that we've just shifted our language from talking about ETR and now we're just calling it PFE. That's not the case. You can have PFE and have bumps on top of it. You can have PFE and not have bumps. You can have PFE and have ocular features. So this is just one feature of a big menu of potential features that you could have with rosacea. I would also say we have a tendency, I think, to want to jump to the conclusion that what really bothers our patients is the bumps that they have on their face. And I would tell you, we have some good survey data that shows it's not just about the bumps. The bumps are important, but it's not just about the bumps. In fact, this was a web-based survey that was done in collaboration with the National Rosacea Society, and over 700 people were surveyed. Now, all of these people, it was a web-based survey, but all of them had been previously diagnosed with rosacea by a physician. At the time of the survey, they were self-reporting that they had mild to severe erythema. And what I'm getting ready to show you, I want you to kind of perk up and pay attention to this. The people were asked, what is your most bothersome symptom or sign of rosacea? And then it was broken down by whether or not they said they had mild, moderate, or severe erythema. But look at the highest bars here on all of this is persistent facial redness. And it didn't even matter if you were somebody who said you had mild erythema, this still came out as the number one answer for what was most bothersome. And it's true for moderate erythema and severe erythema as well. And it doesn't mean those other things should be downplayed. They're all important. But what we should realize is that maybe for too long in the past, we overlooked redness because we didn't have anything to treat it with. But we do now. We don't want to overlook it because it's important to our patients. This is another slightly older survey, but I think still really important. It was over 1,600 people, again, by the National Rosacea Society. And in this survey, 82% of those who suffered from erythema reported that the condition had a negative impact on their general outlook on life. And 90% of them said that that was true if their erythema was moderate to severe, but 82% in anybody who had erythema, which we know is the majority of people with rosacea. So the take home really here is erythema is an important part of rosacea. We need to be identifying it and managing it because it really bothers people. But gone are the subtypes. Forget about that. No longer do we have to try to say erythematotelangiectatic because that's a mouthful. What we're going to do instead is subtype lesions or subtype signs of rosacea. Don't try to fit people into one subtype. And then once you identify those things, treat everything that you see. And probably if you hear nothing else that I say, most of your patients, I think, are going to have more than one feature of rosacea. So most of your patients are probably going to need more than one treatment. We don't need to try to do too much with one thing because we have products in rosacea that are indicated to treat bumps and then separate products that are indicated to treat redness. And we'll talk more about that as we go. I would say that the first visit, when you have a rosacea patient come to your clinic, it is not a fast visit, not the first visit. Maybe if we do a great job the first time, the follow-up can be easy and great and fast. But we have a lot of information that we need to cover that first time. And so I think it's easy to think of just stop. And, a stop sign is red, so it's easy to remember for rosacea. The S is for identify signs and symptoms of rosacea. And when I say symptoms, that means we're also asking our patients, how does this feel? And you ask them, what are the features of this that bother you the most? Because I want to really be sure I target my treatment to what it is that bothers you. T is discuss triggers. And so the triggers are important. What are they triggering? They're triggering pathways of inflammation. And I need to know what those are. And we need to talk about whether or not we can adjust them. And then O, agree on an outcome for treatment. This kind of plays back into the beginning where we're listening to our patients. What's important for my patient is what's going to become important for me. So one person might say, what's most important is that I get rid of this redness. Another might say, I've got to get rid of this burning and stinging. I'm uncomfortable all the time. Another might say the bumps, that's going to be my chief outcome. So whatever it is, we're going to develop a plan then, which is the P, to go about treating that in an effective way. So what I wanted to hopefully get across up to this point is there are multiple targets, even when you just look at a patient clinically. So we haven't even talked about pathogenesis yet, but when you look at somebody clinically, the different features that you see are going to make you pick different treatments. But even if we look at this deeper and we think about this from a pathogenesis standpoint, there's more than one target here as well. There are at least two pathways, and the pathways of inflammation here, or the pathways to the features of rosacea, are also going to require a different treatment approach. So the two main pathways we talk about, one is the bottom left here, and that's inflammation through innate immunity. So when you hear us talking about cathelicidins and LL37, or even MMPs and matrix metalloproteinases, all of that is coming through this innate immune pathway. And we have many products who have their effect here. For example, I would say doxycycline is going to work in this pathway. Most of our topicals are going to work through this pathway. But we also have a whole nother pathway, this neurogenic dysregulation that I've highlighted at the top right. And this is coming through pathways called transient receptor potential channels. And these are channels that when they are activated by things like spicy food, they cause the release of things like substance P or calcitonin gene related peptide. And those products go directly to the vessel and cause vasodilation. And so the point is, you could do a great job blocking this inflammation through innate immunity. But if you're not doing something to that vessel, it's going to stay vasodilated. So, both clinically, we have an opportunity to hit multiple targets, but we also, from a pathogenesis standpoint, have the opportunity to hit multiple targets as well. Another way I've liked to look at this, and I hope this is helpful to you, it's actually been helpful to me, is when we look at a rosacea patient and we look at all of their features, think of that as a menu. And so they've got a menu of multiple different things. Rosacea is not one thing. And so our treatment is not going to be the same for everyone. And yet sometimes we treat it like that. We use the same treatment first line for everyone. And I think that's probably in error. That would be like going to a nice restaurant where you're going to have a multi-course meal and you're going to have soup and salad and steak and potatoes and dessert. But your waiter comes to you and says, I need you to pick one utensil. You're only going to get one utensil. And I think most of us would probably pick a fork. Or a spork, but we don't have a spork in rosacea. That would be something that did everything for us. We don't have that. But if you pick your fork, as you can see here, you do really good until you need to eat your soup. And then you need a more specialized tool to eat the soup. And I think it's the same in rosacea. So in rosacea, let's say we have forks, spoons, and knives here too. So just follow with me. And so we have on the menu bumps. And so we have forks that are going to be great at treating the bumps. Those are the products that are indicated for papules and pustules. That's ivermectin, metronidazole, azelaic acid, minocycline foam, encapsulated benzoyl peroxide, which is coming. And then we have spoons. Okay, these are for that thing on the menu that's the background erythema. That is brimonidine. That is oxymetazoline. By the way, those are our two alpha agonists. We're going to talk more about those here in a minute. But then you might see telangiectasia, or you might even see FIMA. And now we're going to have to use a very different tool. We're going to have to use a knife. We're going to have to use a device-based treatment. For the vessels, pulse dye laser, KTP, IPL. For FIMA, we may have to use electrosurgery. Now, we're talking about erythema and rosacea, and we're really talking about persistent background erythema, but I'm going to detour a little bit and remind us that erythema and rosacea can be a lot of different things. It can be transient erythema, which is flushing. It can be non-transient erythema, which is that background erythema. And again, the diagnostic feature is that one. It's the non-transient. You can certainly flush on top of that, but you've got this background redness that's kind of always there. We've got telangiectasia. And telangiectasia aren't going to go anywhere with a cream, a pill, a topical product. We're going to have to use a device for those. We've also got perilesional erythema, which is redness around the bumps themselves. They're inflammatory lesions. One of the cardinal signs of inflammation is redness. And so that's another type of redness that we're going to see in rosacea. But let's talk about persistent facial erythema in particular. And so here is where we're specifically talking about our spoons. Okay, so all of those forks that are out there that are good for papules and pustules were never designed to help treat the background erythema. That's why we need a more specialized tool. So our first spoon is going to be brimonidine 0.33% gel. This is an alpha agonist. It's an alpha 2 agonist that's separate from oxymetazoline, which is an alpha 1A. So don't think of these as being me too products. They are different. They have different receptor selectivity. This was FDA approved in 2014 for persistent background erythema. It does not treat telangiectasia. It's not approved for flushing. The phase 3 trials with this were very interesting. It was the first time we'd seen trials like this. They did exclude people who had more than 2 bumps. And that's not because we're afraid to use it in people with bumps. It's because in this study, we needed to really be sure we were isolating background erythema. And so we didn't need a lot of perilesional erythema in the way. Now, the outcomes in this study and the ones with oxymetazoline were really unique. It wasn't just what the investigator thought that mattered. It was also what the subject thought that mattered. And so they came into the study with moderate to severe redness. Both the investigator and the subject agreed on that. They didn't get to commiserate, by the way. That was just separate ratings. And then at the different time points when we were looking for outcomes, they had to have a composite 2-grade improvement, which means both the investigator had to think there was a 2-grade improvement, but also the subject had to think so. And they didn't get to go back and look at their baseline pictures. So it made it a little bit tricky. But we did see that this worked, this reduced erythema for 9 to 12 hours. It was applied every day in the morning. And one of the most interesting things I think about these products is how early it did work. So this is all on day 1. And our first endpoint is day 1, 30 minutes. How often do we have a study that has an endpoint day 1, 30 minutes? By the way, the check marks mean 1 check mark means composite 1-grade improvement, 2 check marks means composite 2-grade improvement. We see her at beforehand. Remember, they would not have been able to see that picture, but we can see the difference at every time point compared to baseline. And I've always noticed that this doesn't just work to 12 hours. This is still working at 12 hours. Now, oxymetazoline is not a me too. It is also an alpha agonist, but it's an alpha 1A receptor agonist. This was FDA approved in 2017, and it's similar in many ways to brimonidine in that it's not going to treat telangiectasia because they don't have smooth muscle that's still functioning in the wall. Also not approved for flushing. They also had to have a composite 2-grade improvement, and we have very early time points with this as well. So here we see the person at baseline. The top row of photos here is day 1. The bottom row is day 29. And so I think we can see again, especially when we can compare back to the pre-dose at baseline, we can see an improvement at every single one of these. Here, instead of check marks, we're seeing stars. So 2 stars mean a 2-grade composite improvement, and 1 means 1-grade composite improvement. Now, there's no head-to-head studies that are going to compare oxymetazoline and brimonidine, but there are different receptor selectivity to these. And I think that, at least in part, probably explains why we've had a little different experience with these in our clinic. It may have to do where the receptors sit. Alpha 1A receptors are only postsynaptic. They're only on the vascular smooth muscle. Alpha 2 receptors are located both there, but also presynaptically. And the hypothesis as to why maybe we see a little more potential worsening of erythema as brimonidine wears off, or even the paradoxical erythema that can happen around hour 6, is that if you're also working presynaptically, you could inhibit norepinephrine and then actually lead to vasodilation. And this is just a schematic that kind of shows us where those different receptors lie. Now, this was this continues to be a game-changing study for me. This was published in 2018, but this was the 52-week safety study for oxymetazoline. So the long-term studies are usually about safety more than they are about efficacy, but I learned something about efficacy here too. And when we look at this study, there were 440 people in the study. Everybody had moderate to severe erythema at baseline. They applied oxymetazoline daily for 52 weeks. Now let's stop there for a minute, and I'm going to do some true confessions. And so when you have a product that one of its time points is day 1, 30 minutes, and we see how well this can work in 30 minutes, or with oxymetazoline at 1 hour or 3 hours, this has a rapid onset. And we know that people are either going to like it or not like it, probably on the first day they use it, which made us think, you know what, use it on the days that you don't want to be read. And on the days you don't care, then don't use it. And then you can make it last longer. But that's really not the way it's indicated. And I think what we're learning is it's probably not the best way to use it. So when you look at somebody who's got that fiery red erythema, and we know that they're also uncomfortable, they're hot, they're burning and stinging, that did not happen overnight. And so my thought has become, it probably makes sense then not to just vasoconstrict every now and then. If we really want to try to improve that and potentially even reverse that, we're going to have to vasoconstrict on a more consistent basis. To me, in the med derm world, it's like stasis dermatitis. You don't treat the stasis dermatitis and then say, oh, go ahead and start swelling again, it's going to be fine. We know what will happen if that happens again. We've got to use compression in the background. We're keeping people in compression stockings. In the cosmetic world, it's like taking somebody who comes in for toxin injections in the glabella, and they've got fairly deep 11s in the glabella. And they are, let's say they're 55. So they've been making that expression for 55 years. You do one treatment of toxin, you've relaxed the muscles, they're not moving, but the lines are still there. And they come back in and they say, why are the lines there? and you explain you have been reinforcing those lines for your 55 years. It's going to take more than 2 or 3 weeks to undo that. We're going to have to consistently treat you with toxin and help you to quit reinforcing those lines so they eventually go away. And I kind of think that's what's happening here. We have got to consistently constrict these vessels in order to maybe get a more meaningful change down the road. So this is looking at composite 2-grade improvement over 52 weeks. So on day 1, the orange is going to be hour 3 and the gray is hour 6. The blue that's going to start popping up is before they even put it on. And so, of course, on day 1, nobody is meeting the endpoint before they start the study, or they wouldn't be in the study. But not a small amount are meeting that 2-grade improvement composite at hour 3 and hour 6. But even more are by week 4. So is there a little bit of an additive effect over time? By the time you get to week 26, now 6.5% of people, before they even put it on, have met the endpoint. And when you get to week 52, now 1 out of 10 people have met the endpoint and they haven't even applied the medicine yet for the day, but they've been applying it for 52 weeks. And I think this shows up nicely in pictures. This is out of the publication. So this is the top row is this guy at day 1, and then the bottom row is this guy at week 52. We see him at pre-dose hour 3 and hour 6. I'll just kind of hone right in on the pre-dose on day 1 and then pre-dose on week 52. And you've got to ask yourself, do you think he's getting a benefit from using oxymetazoline every day for 52 weeks? And I think the answer clearly is yes. Now, this is a safety study, so I don't want to leave this part out. So when we're talking about safety, what we really want to know in a long-term study is, as people stay on this longer, do we see more adverse events pop up? This is broken down into quarters. And so we don't have a high rate of adverse events anywhere here, but if we're going to see them, it's going to be in the first quarter. As you go across the time of the study, we don't see any safety signals that pop up here. Okay, flushing. I do want to spend just a minute here. There's nothing FDA approved for this, so I can't really even call this a spoon. We're just kind of out there. Do I think the alpha agonists help with flushing? I think they probably do, but that's not the way they're approved. That would be an off-label use for those. I think this was a helpful article in the JAD in 2020 that was just a review article of using the oral beta blockers to treat flushing. So this included looking at carvedilol, nadolol, propanolol, and we know these cause vasoconstriction in the skin by blocking beta-2 receptors on smooth muscle of cutaneous arterial vessels. All of these have been studied in rosacea, but none of them are FDA approved for rosacea. They can have adverse events. They're the ones you would expect, since these can also be used for blood pressure. They can decrease the heart rate. They can lower blood pressure. They can leave a person feeling weak. They can cause dizziness and vertigo. And then this is also a helpful study. And this is carvedilol. It's really just a case series. This was out of Europe. So some of the treatments you'll see here maybe are a little different than what we would use. But this was 5 patients with either severe frequent flushing episodes or persistent erythema and burning sensations. Their prior treatments, and here's where some of them are a little odd, included cetirizine, doxycycline, or isotretinoin combined with a topical application of Metrogel or ivermectin, and they didn't notice sufficient improvement. And on many of those, if not about all of those, I'd be like, well, I wouldn't have even expected to see much improvement in the erythema based on what we're using there. So carvedilol was added to. It was not replacing anything. It was added to what they were on. It was titrated up to 12.5 milligrams twice a day, and it was continued for at least 6 months. And here's a picture of this guy. I think it's hard to take a picture of flushing because it's transient, but here's an effort. I think you do get a sense that maybe this is flushing, and then we see him after treatment. And if you want to try to make this more objective, they did look at CEA and PSA. CEA is the clinician's erythema assessment. PSA is the patient's self-assessment. High bars mean lots of redness, and then during therapy, those bars had come down. I also like this study. Excuse me, I like this study, but it's not a perfect study. So this is propanolol and or doxycycline, because I know what you're thinking, because I think it too. So doxycycline is anti-inflammatory, and a cardinal sign of inflammation is redness. And so doxycycline is going to help redness too. So let's kind of compare. The problem with this study is it's not randomized, and this is before the phenotype approach. So we're still going to go back and use old language, and we're going to talk about people with ETR, erythematotelangiectatic rosacea, and people with papulopustular rosacea. And when I say this is not randomized, what I mean is if you got the propanolol treatment, then you probably had ETR. In fact, it was 19-3. If you got doxy, you probably had PPR. And in fact, it was 11-4 in favor of papules and pustules. And then there was a group of people who got both. They got propanolol and doxycycline. And this was a little more even, but not really. It was 17 who had PPR and 9 who had ETR. The dosages here, by the way, I think doxy was 100 BID. I know the propanolol was 10 milligrams TID in this study, but let's look at some pictures. By the way, these are skin of color patients. We don't want to forget that skin of color patients can have erythema. They can have rosacea, even people with darker skin types than this. Sometimes you need to ask your patient, are you red? Because it may be difficult for us to assess that sometimes, but all of these clearly have redness. So the top row is an example of a 72-year-old that they classified as ETR. She was on propanolol, and we see her at week 4, 8, and 12. You do get a sense that this worked pretty quickly. The second guy got doxy. Boy, if you call him papulopustular, you can see where you're missing the boat on redness because he's got a lot of redness. And I don't think it's all perilesional redness, so there's doxy. And then the last one, this is a combination. And I think she's a combination of features. So that one to me makes the most sense. She looks like a whole different person by the end of this study. And so when we looked for outcomes here, what we found is that both of these worked. The groups that had propanolol in them did show more rapid improvement than the doxy by itself. And I think that stands to reason. Doxy takes a little longer to work. Propanolol comes in there and constricts just from day one. And so those seem to work a little bit faster. Botulinum toxin is another option for people who flush. There have been several reports of this now. This is looking at 2 cases of refractory flushing and erythema of rosacea. So the picture I'll show you is a 36-year-old woman with persistent facial erythema for over 2 years. She had been treated. Listen to this list. Some of these in here we would expect to help: minocycline, antihistamines, carvedilol, methylprednisolone, topical tacrolimus, topical metronidazole. She was subsequently treated with 2 treatments of intradermal botulinum toxin at 1-week intervals. And I can tell you, I didn't put the recipe in here, but it's very, very dilute. I've done this just a handful of times. I have had success. I don't have anybody though right now who's doing it consistently. And I think part of that has to do with cost because I haven't had luck getting this covered by insurance, but kind of injected just in a little grid across the affected areas. But we see her before and after, and you can certainly see a reduction in erythema, and this patient as well. Okay, so to this point, we've talked mostly about erythema, but there's a full menu of rosacea, and I want to talk a little bit about combining treatments and combinations of treatments. We do have combination studies out there. When I finish up here in just a little bit, we're only going to talk about one of these, but I will tell you, a lot of the studies combine 2 forks, and I'm okay with that because sometimes you need 2 different forks. And in most of these cases, the combination studies do still show better improvement or faster improvement. So we've got doxy and metro, we've got modified release doxy and metro, doxy and azelaic acid, doxy and ivermectin. And then now we've got a fork and a spoon here, ivermectin and bromonidine. Now we've got a knife and a spoon, pulse dye laser and oxymetazoline that show those can be used together and give us a better outcome. So we do have combination studies. Why do we even want to do combination therapy? First of all, because we have more than one feature to treat. But I think the real goal is to get people not just better, but to get them clear. And we can do that better using combinations. We can also get them better more quickly. We can maximize how long they're in remission. I want my patients to spend more time in their lives clear or almost clear and not trying to get there. And then when we do that, we're minimizing burden of disease. So let's look at this last study. So this is efficacy and safety of ivermectin topical cream and bromonidine topical gel in people with moderate to severe rosacea. So everyone in this study had to have moderate to severe bumps, and moderate to severe redness. So it was both. And then you were going to be randomized to one of 3 groups. You were either in the top group, which meant you got ivermectin every day for 12 weeks, and you got bromonidine gel every day for 12 weeks. Or you were in the second group where you got ivermectin every day for 12 weeks, but we waited 4 weeks and then started the bromonidine for the last 8 weeks. And they're thinking early on with that, well, if somebody has a bunch of bumps and you take away the redness, you just took away the camouflage. And so we wanted to know, how does it work if you delay versus doing both from the get-go? And then the last group just got vehicle of each of those. This just reminds me that they were moderate to severe on both the bumps, but also on redness. Now, it's important that we look at IGA assessments in rosacea. IGA assessments usually are going to talk about bumps and erythema. And one of the main points here is to be a success, you have to be a 0 or a 1. But let's say we got rid of every single bump on you, but you still had mild erythema. That would make you a 2 here. So you have no bumps, but because you have mild erythema, you're going to be an IGA of 2. And so this is kind of a hard bar in rosacea because we're looking at 2 different features, but now we're using 2 different tools. This is at week 12. The green are the people who got vehicle. We do see a vehicle effect here. That's why we have this arm in the study. And the reason there's 2 green bars is the H0 is hour 0 and the H3 is hour 3. So hour 0 is before the bromonidine is applied. H3 is 3 hours after the bromonidine is applied. But the highest bar on here is the one all the way at the right. And that's the group that used both products every day for 12 weeks. And so that even worked better than delaying for 4 weeks. Just using them both worked better. But, to that point of, well, this person has been on, and I've honed in here on week 12. This is just week 12. This is hour 0 and hour 3. So you've been using a very good fork every day for 12 weeks. It is an anti-inflammatory. But somehow still, there was enough redness left over between hour 0 and hour 3 that once you applied the bromonidine and got that vasoconstriction, you're now able to call twice as many people clear or almost clear. And I don't think that's because there were bumps left behind that all of a sudden went away in 3 hours. I think that's because there was still redness and we need a different tool to really treat that redness. And so I think that's the difference here between hour 0 and hour 3, even when you're using both of these products every day for 12 weeks. So the take home there is targeting inflammation in papules and pustules does not necessarily translate to less background erythema. In fact, it probably does not. All right, so I'll finish up here and I'll leave us just with this thought. Rosacea is a full menu of features. All of them are bothersome. Talk to your patients, learn what it is that bothers them the most, but don't try to do too much with one tool. Pull out all of the tools that you have, use them to try to get your patients as close to clear as you possibly can. Thank you so much for your attention.
Thanks again to Dr. Harper for providing this excellent presentation on persistent erythema and rosacea. We would also like to take a moment to thank EPI Health for its support of this webinar through an unrestricted educational grant. The National Rosacea Society offers professional memberships to dermatologists, dermatology physician assistants, and nurse practitioners to help attract new patients, enhance patient care, and support research. Professional membership in the NRS includes a listing on the physician finder page of our website, rosacea.org, access to patient education materials and consensus publications on rosacea, and a membership certificate and office display. Your donation will support the NRS Research Grants Program to fund important studies toward advances in the management, prevention, and potential cure of this widespread disorder. To learn more and to join, please visit the physician section of rosacea.org. Thank you again for joining us this evening for this webinar and for your dedication to treating patients with rosacea. Good night.